I'm Ignatius, one of the orthopedic registrars from East of England, and welcome to tonight that we're talking about acute compartment syndrome. We'll concentrate on the lower limb, which is what the bread and butter is for compartment syndrome, and we'll take any questions towards the end. So the welcome to the core training orthopedic teaching by East of England, and we're on the second topic now, and we'll be going on to open fractures next week. There are some gory pictures out there will represent the East of England. The pictures are all from Google Images, and we'll upload this video to YouTube as well. Some references from Google journals, and it's all open access. I have an interest in lower limb trauma, and I've done a few fasciotomies now, both acute and chronic, as well as for fractures and non-fracture related. So it's a whistle stop all the way from what you need to know as a medical student to FRCS. Concentrating a bit on interview format, and this is where we represent. There are some events within East of England, as well as following us on Twitter for all the exciting stuff. The YouTube links, I will put it on the YouTube channel on what you need to know. So a few things from AO Trauma North America on compartment syndrome, and that was their update on their last year's webinar. There is a Stryker video on how to measure compartments using their product. There's a way to do compartment pressure monitoring using arterial line by the Liverpool orthopedic team. And there is a textbook out there on open fractures with a specific chapter on compartment syndrome, which was written by the Limb Reconstruction Society, Plastic Society, and Royal College of Nursing, those who wrote the BOST standards for trauma. So a bit of this talk is surrounding the British Orthopedic Association for Standards for Trauma. So for some of you who are core trainees who are coming up to the interview, this is the document you need to know. It was updated from 2006 to 2014. And the only thing that is in the guidelines in NICE for complex fractures is about tibias, where it says you can regularly record clinical symptoms. You should do continuous compartment pressure monitoring or consider. They deliberately left it vague. And when you discharge the patient, you should warn them about signs of compartment syndrome. So we'll talk about what the UK practice is, focusing on ST3 selection, a bit of MRCS, a bit of what UK medical students will want to know. And the articles are mainly British and American based. We care about it because it's a critical case-based discussion towards the end of consultancy, and core trainees need to know a bit about it. What is it? How do you diagnose it? What kind of common problems we get, especially during on-call? How do you get query compartment syndromes? It's a bit like caudate equina, where you get referred quite a lot of them and you don't quite know what to do with them. To start with, we'll end it with some cases and we'll recap. So if you all would like to think of a case of when you last saw a query compartment syndrome, otherwise I'll give you a case where we will discuss it towards the end. An elderly patient, 74, had a long lie with 16 hours long lie, a CK, admission CK, creatinine kinase of 48,000, an EGFR of 34. He transected his cord with a fracture at C6-7, and he is functionally quite bad with spinal cord injury. If you're all listening at home on your desk, if you could get a piece of paper to draw a cross-section of tibia and fibula midshaft with muscles and neurovascular bundle, because that's what will come up in the SC3 interview as sometimes on the anatomy bit, and draw where you would do a fasciotomy. If you've got a leg, you can draw it on yourself if you wanted to, which is what I will show you a few of them. Or if you can have a piece of paper and think about it, it will all come back to this. This is the MCQ that some of you have done. A 19-year-old, day one post-op tibial nailing for mid-shaft closed tibial shaft fracture. He's in a lot of pain post-operatively. And what muscles will be released when his anterior compartment is relieved? Tibialis anterior, peroneus longus, gastrocnemius, flexor digitorum longus, and tibialis posterior. So have a think and we'll talk about it later. And which of the following provides aid in diagnosis of compartment syndrome? An absolute pressure of more than 30 millimoles mercury, a delta pressure of less than 30 between pre-op diastolic blood pressure and the affected compartment, delta pressure of less than 30 between pre-op systolic blood pressure and affected compartment, delta pressure of less than 30 between intraoperative diastolic blood pressure and affected compartments, delta pressure of more than 30 between post-operative systolic blood pressure and affected compartment. Now, most of you would remember that compartment syndrome is a clinical diagnosis, is a syndrome, can be caused by anything, including fractures, burns, crush injury, blunt trauma, or big hematoma, with a clinical examination that can give you the 6 Ps: paresthesia, pulse, paralysis, pallor, and pressure. However, as you progress through core training, and as a foundation doctor, if you come to orthopedics, most of us will normally say pain out of proportion of the affected compartment on passive stretch. So that is the actual number of P's in that sentence. So pain on passive stretch out of proportion of the affected compartment. It is because of any reason. So say the most common one we get see for query compartment is a tight cast post-operatively. It causes increased pressure, increased capillary pressure on the venous system that decreases the perfusion pressure, and it causes the cells to die, and it causes a vicious cycle. This is directly lifted off AO and BOST, where you have a discrepancy between the muscle perfusion pressure that leads to this issue, where if you were to measure, and now this comes back to a syndrome where you use compartment pressure measures as an aid, it would be a preoperative diastolic blood pressure, and the difference of that affected compartment is less than 30 millimoles mercury. It suggests an increased risk. So it's all deliberately vague. If the absolute compartment pressure is more than 40 with clinical syndrome, then you should consider a fasciotomy. Now, so in both, it clearly states that it's a collaborative thing where the Royal College of Nursing has an observation chart on teaching you how to passively stretch a compartment. So if we're focusing on the lower limb, if it's anterior compartment, you want to bend the big toe, EHL, extensor hallucis longus, or flexor hallucis longus if you're looking for deep posterior compartment. And they should have a routine nursing limb observations for early signs. And you should always go back to this chart. Some hospitals won't have it. What blood test can we use? So the problem with CK, which is what probably most people will think, okay, the first thing you should do is a CK, is that it is delayed by more than 6 hours. It relies on ischemic time. It relies, you can stick a probe in, and this is all research-based, whether or not there's decreased pH, the oxygen level, the glucose. There is a viva question in the MRCS where historically you could treat patients with rhabdomyolysis with mannitol, or at least get HDU involved. And the problem with CK is there's not a real cutoff, and when do you actually measure the CK? It is a good way to measure if you've got a serial CK to see if the rhabdo has resolved with renal function that supplements the MDT approach, so especially a patient if they've gone to HDU for single organ failure. And this is just the biochemistry behind it, why we care, because you get renal ischemia and renal failure. But this is probably your day-to-day bread and butter, where you ask to see a patient. You can see all these are clinical pictures of what you want to know and what you need. So most commonly it's because of a tight cast. So you want to take them down to remove the wool. Your friend would be elevation. So methods of elevation, including increasing using the bed control. These are some clinical pictures from the mirror where a patient was elevated using a plastic bag, as well as a modified Bradford sling, which is using a pillowcase, or the blue one is an actual Bradford sling. When you look at pain out of proportion, so how you quantify that is using drug charts. You can use other elevation methods, such as a pillow, where the ankle is above the knee, or in upper limb situations, you want the hand above the elbow, the wrist above the elbow, above the heart. You want to look at what the renal output is. And in certain scenarios, you can dip their urine for myoglobinuria, which is very similar to color of Coca-Cola. That is when these are some situations. Or if you're first on call with your registrar, these are some of the situations you get referred. So whether it's a burns patient, a hematoma, blunt trauma, fractures, infection, such as a viral myositis or bacterial myositis, a long lie from a patient, or a patient that has had illicit drug use and has had a long line, or an injection into a compartment, or bleeding. So you typically get this really shiny looking skin when the patient goes onto the table. And this goes back to, again, you want to measure the affected compartment. So there's no point saying the patient's in a lot of pain, but which compartment is actually most affected. So if you want to recap again, extensor hallucis longus, if you want to look at anterior compartment, it's difficult to measure peroneal longus in the tibia anyway, especially if they're a fracture situation in the back slab. FHL, flexor hallucis longus, for the deep posterior compartment. An anterior compartment is probably the most, in an MCQ setting, an anterior compartment is the most commonly affected compartment for fasciotomies. Now, so if you stick a needle in, is there any diagnostic certainty with sticking a needle in? So the methods of doing it is, in a commercial setting, would be Stryker, but they've stopped doing this because they weren't making a lot of money, because you can use a generic syringe and a generic needle that sticks into the actual compartment. So in this diagram, you can stick it into anterior, lateral, deep posterior, superficial. So each and every one of them needs a separate needle if you wanted to measure each compartment. And each hospital should have their own policy. If you really are still uncertain and you do not have the Stryker probe ready, you can always bring them to theater and set up an arterial line with your friendly ODP and measure that using an arterial line. So when you consent the patient, say you think, okay, this patient's got pain out of proportion on passive stretch of the affected compartment. You want to tell them it's going to be like a balloon where you want to pop it so that you make sure that the muscles don't go dead. After a few days, you want to be able to bring them back to the theater to see if you can close them, a bit like if you've wrapped the dumpling too tightly. If the fillings just want to pop out. So 48, 72 hours, whether you want to see if you can seal that muscle back on again. And the whole point is to give them a salvageable limb with no contractures or minimal amount of contractures. So just to recap, and this will come back to what is an actual compartment syndrome. So now that you've cut the muscle or cut the fascia, if the muscle bulges out, is that compartment syndrome? If you're able to close the skin after 48 hours, is that not compartment syndrome? We've talked about pain out of proportion on numerous occasions, and how much painkillers do you need to give them? The Bose Standards for Trauma specifically says you have to repeat your examination every 30 minutes to an hour, and you see what the response is to analgesia, and as well as elevation and trimming down any kind of soft tissue obstruction, such as a cast and wool or bandage. If you stick a needle in, if that compartment says more than 40, is that an affected compartment? If the pressure is less than 30, how long is that? So the only data out there which is from one of the biggest units that do compartment pressure monitoring, is Edinburgh. It states that it's over 2 hours or sustained over 2 hours. Should you do a prophylactic fasciotomy? So it's just a question to ponder for everyone. Is it better to have false positives than the missed one? But if you've done a false positive, what are the complications? Neuroma, scar, CRPS? And the time to surgery, specifically in BOST, it states that within an hour, you need to do an urgent surgical decompression. Now, there are papers that you can quote to go as soon as possible, or what the cutoff is to get the best outcome. And these are just some papers that will be available on YouTube for you to have a look at. So we won't dwell into how many hours, but as soon as possible. And this is probably the most famous leg I can tell from BOST, where it tells you where exactly do you need to draw to decompress the compartments. And I'll explain what those actual lines are. And if some of you have drawn on a piece of paper what you think those lines are, we can tally it up. Okay. We'll talk a bit about why you do certain things. So if you go back to the blood vessels on the medial side, you always look for perforators because your plastics colleagues might do a myocutaneous flap, such as the picture on the right. And if you don't label the angiosomes, the perforators, there are angiosomes or choke vessels where you can turn a really simple procedure and you can potentially make that flap die off. So these are some of the reasons why you always need to approach this using an MDT approach with the plastics team involved as to what the reconstructive options are. The cross section, which I've asked you guys to draw on the compartments, would be if you want to do an anterolateral incision to decompress the anterior and the lateral compartments at the same time, and a posteromedial incision to take off the deep and superficial compartments. And the neurovascular bundle is between the anterior compartment and deep posterior for anterior tibial artery and deep peroneal nerve. And the posterior tibial artery and tibial nerve is between the deep posterior and superficial posterior. And we'll come to why this is important later on. There are some sensory nerves that you need to watch out, which I'll explain. Just to recap, anterior compartment, lateral compartment through an anterolateral approach, and posteromedial incision to decompress the deep posterior and superficial posterior. Your reference points would be your anteromedial facet of your tibial, the face of the tibia on the anteromedial side, which is a triangular shape in the midshaft, and it slowly becomes more square shaped towards the distal end. But just remember it as a triangle. There are loads of YouTube videos out there to explain what these compartments are, so I won't delve into it, and what the individual muscles are. So you should be able to label them if you're coming up to the interview. Now, why do we care in terms of the superficial nerves? So if you were to do a lateral incision for a deep posterior and a superficial posterior, the thing you have to watch out for would be your superficial peroneal nerve that comes about 5 centimeters from the distal tip of the distal fibula. So sometimes it crosses over or it comes piercing through the fascia. So just as you're going distally on your lateral incision, just be careful of that one. So this is just another picture to show that a bit more clearly. And this is my leg that I've drawn. So this is the lateral incision, anterolateral incision to get to the anterior compartment and the lateral compartment through a single incision. You want it to be roughly 2 centimeters. You can afford to go slightly more lateral to allow for a bigger skin bridge between the medial incision and the lateral incision. Because as the compartments become more swollen, a 2 centimeter when the swelling comes down might not be 2 centimeters. So go a bit more lateral in this situation. Your superficial peroneal nerve, which I've labeled, will come about 5 centimeters from the tip of the distal fibula. So just as you're going distally, just watch out and look for it. On the medial side, the superficial sensory nerves are the saphenous nerve that goes with the saphenous vein. So just look for it and don't cut through it. Now, you've found and labeled the anteromedial face of the tibia. You go 1.5 centimeters. Some places will say 12 to 15 millimeters. That's in the textbooks. The reason why is because if you go to 2 centimeters, like the lateral side, you will come across perforators. So if you look for the tip of the medial mal, you label it 5, 10, 15, 20, 25 centimeters. Most of the time, you will find a perforator if you go too posterior or too medially. So always label them. Or if you have plastics colleagues there, ask them what they actually want to do. And some of them will actually on table use a Doppler to look for the perforators. So try not to cut them in case you turn a simple procedure to a difficult procedure. And in the medial incision, so in the lateral incision, so this is of the left leg. So if you're doing a lateral incision, the problem is if you can go slightly posterior to allow for a skin bridge between the medial incision and the lateral incision. The problem is if you go too anteriorly, you might think that you've taken off the anterior compartment, which you think that you have taken a compartment. The problem with the lateral incision is that, remember we talked about one of the neurovascular bundle is between the deep posterior and the superficial posterior. If you haven't found that neurovascular bundle and you haven't felt a pulse, that means that you haven't decompressed the deep posterior compartment. It's very easy to just take off superficial posterior. Sorry. We'll just go back to the medial incision now. So if you do the medial incision, it's very easy to forget to decompress the deep posterior compartment. In the anterolateral incision, sorry, I have my mistake. In the anterolateral incision, if you go too posteriorly, you might forget to release the anterior compartment. So if we go back to the Bost picture, which is this one, the common mistake that people make in releasing the anterior compartment is they try to use a periosteal or try to take skin off to try to get to the lateral compartment on a separate incision. So as this diagram states, on the anterolateral incision, take the anterior compartment, go as lateral as possible, and find the lateral compartment and take the lateral compartment off without taking any skin or fascia, because that's where the blood supply comes from. Okay, so recap: anterolateral incision, 2 centimeters from the lateral edge of the anteromedial face of the tibia. The incision on the medial side is 12 to 15 millimeters, taking off, decompressing the deep and superficial posterior compartments. These are some of the pitfalls. We always talk about double incision. There is a method described out there where you talk about single incision perifibular fasciotomy, but no, it's just there's a lot of pitfalls in that approach. So in the UK, we talk about double incision, which was described back in the 80s and 90s. Prof. McQueen in Edinburgh did this piece of work in 2000 where it talks about the reason why every single MCQ question out there always talks about a tibial shaft fracture is because in a younger patient, you have a higher risk of fasciotomy or compartment syndrome, sustaining a tibial shaft fracture, spoiling a sports injury. So that's the most common scenario in 30% of the time. But never forget, other places that can get compartment syndrome include soft tissue injury, a distal radius fracture, crush syndrome, long lies, a forearm fracture, even a femur fracture. The most common mechanism of injury will be sports, or road traffic accident, crushing injury, or fall from standing height. And the younger you are, the riskier you are for compartment syndrome, especially in male patients. And they stuck a needle into every single compartment for every single patient that had injuries, and they've concluded that they had a high sensitivity and specificity for these patients. And the way they did it was, which kind of shaped what the BOST standards for trauma today is, and what today's practice will be less than 30 millimoles mercury difference in terms of diastolic, pre-op, and the affected compartment for more than 2 hours. They describe a double incision technique. And if you can close the wound within 48 hours, that is not a compartment syndrome according to their guidance. So that is where their false positive comes in. So the AO trauma debated this and stated if there was a big blood clot in that compartment, you can still actually close the wound. If you have a patient that's going to theater and in the whole brief, they will ask you things like tourniquet, antibiotics, and blocks for these patients. I tend not to use a tourniquet. You may apply it in case you hit a blood vessel, but don't inflate it because you want to feel the blood vessel and the pulse. You want to give antibiotics until the wound is closed. And if you were asked to give a regional anesthesia, in BOST in 2014, it says should be avoided. But the recent guidance in August 2021 in Anesthesia and Royal College states that there is not a big RCT out there to say what the efficacy is. You should not give a dense block or a dense spinal. You should give as low dose as possible. And there should not be any discrepancy between what the anesthetist feels is best for the patient. So that's in that guideline. And this is the textbook that I've just to recap, we've talked about where the posteromedial incision is and the lateral incision is. All wounds should be closed within 72 hours or at least covered with a split skin graft. And in common practice, you would hear all of us, if you've done orthopedics, to say, oh, a second look or third look of the wound in 48, 72 hours anyway. And to recap, this is translated from the Prof. McQueen's paper into this book. It's less than 30 millimoles sustained over 2 hours. So this clinical photograph is what we've seen during the start of the talk, where there is a clear, shiny looking skin. The compartment looks really tight. And when you put an incision on, you should see this is the shiny, glistening bit of the fascia that you want to decompress. After the decompression, you should see that the muscles bulge out. So it's either looking really dusky and brown to begin with, like a steak that has been left out, like those Tesco ones that have been reduced. And once the compartment is released, it's nice and pink. You can do clinical evaluation on the table, such as pinching it with forceps. You can flick it with your finger, or you can use a diathermy to try to cause a flickering of the muscle to see if the muscle's dead or alive. If the muscle's clearly dead, you have to take the dead muscle out. And the scars look horrible, which we've talked about. If you've decompressed all of them, you will have false positives, and they don't come without any risk to them. So just to recap again, the perforators, this is the reason why you want to have your plastics colleagues and as an MDT approach to doing a fasciotomy, if you have the luxury of having plastics on site. And we'll talk about open fractures next week. So when you're doing a fasciotomy wound, you can always do a rotational flap that respects the perforators and angiosomes. And you always want your plastics colleagues to be there. And if you're doing a posteromedial incision, you can always extend up and rely on a gastroc flap or a myocutaneous flap, or you can do a free flap for any of the plastics colleagues out there to cover the wound. Closure. So this is a topic of huge well, it's a lot of debate really. So we always put a vacuum dressing on, and specifically, you always put a negative pressure foam dressing and you put it on 50 to 70 only. Within 48 hours or 72 hours, you would quite like the patient to have split skin grafts. So if you think that from the onset in a district general, you can't close the wound, transfer the patient to nearby plastics unit. There has been talks about whether you should use a shoelace type wound with staples, or where you should do a primary closure. There is a paper to support that shoelaces can have 100% primary closure rates versus just using a vacuum dressing. But always discuss it with your other colleagues. And just for those who are coming up to the interview, the reconstructive option is not a reconstructive ladder. So there are some orthopedic consultants out there that know how to do split skin grafts, and it is one of the options to close a fasciotomy. So if you have the expertise and you work in the limb reconstruction unit, it is a reconstruction supermarket, not a reconstruction ladder. If the patient has had a delayed presentation or late diagnosis, depending on the compartment that has necrosed or gone into contracture, say, for example, for more than 12 hours, you ideally want 2 senior colleagues. So in the both standards, it specifically states that you need 2 consultants to make that decision. Okay, so we've got the original case. Is there anyone that would like to discuss this case? So a long lie after fall, 16 hours with a raised CK. So we'll apply all the knowledge that we've discussed this at the start of the talk, with a clear acute kidney injury. Potassium's borderline with not much medical history, and he's had a spinal cord injury causing that long lie. What's your initial management, and how would you go about managing this patient? Is there any volunteers? Especially Gordon.
I can go.
Go on. Okay.
Yeah, it's Gordon here from Lister Hospital in Stevenage. So you said was it initial management? And
yeah.
Then you, okay. So my initial management approaching this patient, I would make sure that this patient's had a significant injury. So I'd make sure first and foremost, ATLS protocols have been followed, secure. This patient has a spinal injury. So I'd make sure that the C-spine is secured, triple immobilization, collar blocks and tape, ensuring that the airways, breathing and circulation and disability are simultaneously assessed and managed accordingly. Going on to a secondary survey, patient would need a detailed neurological assessment that is documented on an Asia chart, and then paying closer attention into the lower limb in question. I would make sure that any dressings, occlusive dressings, have been removed. I would elevate the limb to the level of the heart and then perform a detailed examination of this limb. I would pay close attention to look at the skin, at the soft tissues, make sure, identify if there's any fractures that need to be splinted at the time. And then I would palpate the compartments, feel for tense compartments. And then my main clinical, I'd want to assess in A&E the patient's levels of pain on passive stretch. I'm aware this patient has a spinal injury, so we may have limited findings in the sense of pain. So I'd have to have a high level of suspicion to take, not only to measure the compartment pressure, examine the compartments with their tensioners, but also get a formal compartment pressure, whether that be in A&E or in an operating theatre. If there was any, I'd want to escalate the issue to my senior colleagues, not only in orthopedics, but in the anesthetic colleagues, keep them nil by mouth, and also plastic surgeons as well. The other things I'd want to think about at this time is getting some medical or ITU input for his renal function, which seems to be off, get an ECG, and work this patient up because they will need to go to theatre. I think we should huddle before theatre and have input from ITU, plastics and other teams as well. I think that would be my initial management, but I think we'd also need to contact the spinal unit and get a plan for the transected cord and manage that accordingly.
Perfect. Spot on textbook answer. You are the tertiary center.
Okay.
The spinal injuries unit on board. This patient's starved. As you rightly said, they have no sensation beyond the C6-7 level. So what is, how do you measure compartment pressure?
There's a few ways we can measure compartment pressure. So we could use a compartment pressure monitor. That could be, so that's a striker compartment pressure. There's other ways that you can measure, sometimes with an arterial line. You could use simple measures with a green needle and also a syringe with, I think, about 5 to 10 mils of saline in. But so that would be ideally the ways that I would know of.
What gives you a reading, and how do you interpret the readings that you get?
So I would need to have a simultaneous diastolic blood pressure of the patient. I would assess the compartment pressures, and I need to assess all 4 compartments: anterior, lateral, superior, superficial, and deep posterior. And I would measure the compartment pressure. If I had a delta P, which is the diastolic minus compartment, if that was within 30, I'd have a high suspicion of compartment syndrome. If I had a compartment pressure that was over 40 as well, that would also be diagnostic for compartment syndrome.
Perfect, because you're doing well. We'll keep going. If the patient doesn't have spinal cord injury, so coming back to basics, how would you isolate the sensation of the lower limb? So how do you measure the individual?
So I would ensure that, again, all the occlusive dressings are off. I would to measure the sensation of the dorsum of the foot, would identify the superficial peroneal nerve, which would be the lateral compartment. The first web space would be the deep peroneal nerve, identifying the anterior compartment. And then I think sole of the foot for the tibial nerve for the posterior and posterior superficial deep compartment.
Perfect. And just for completeness, you can look at saphenous nerve, which is...
Yeah.
But most of them will be defunctioned in the elderly. Okay, good. Well done. So we'll go to the next one. 34-year-old, quite muscular bloke, had a motorbike, fell on his leg. He was started on dalteparin, brought back to the DVT clinic on Monday by ED on Friday. He represented on Saturday, I think I was on call, on Beatrice, after discharge by ED with pain and unable to weight bear. His X-ray is NAD. So any other volunteers? Anyone coming up to the interview? Who's LL? Govin, do you want to go again? Given that you've done so well.
I don't mind going again. Sorry, do you mind just repeating the specific questions that you wanted? It was just how to assess.
The question, well, you've done really well. So you've, in the previous case, so they always in the situation in the interview, they always ask your initial assessment. So you've done it for the previous one. So how about we go to another one where the third case is, which is the typical SC3 question. So
okay,
18-year-old rugby tackle with a deformed leg, potentially head injury, query open, query pulse, and a lot of pain. So what's your initial management of this patient?
Okay, so this is a significant mechanism of injury, and injury is identified initially. So my initial management would be within the presence of a trauma team. I would manage this patient according to ATLS protocols, ensuring the spine is secured. I would have a simultaneous assessment and management of the airways, breathing, and circulation, assuming I'm aware that there's a head injury, so I need to do a formal assessment of this patient's disability. On my secondary survey, I need to include a neurological assessment of the cranial nerves, and also the looking for signs of a base of skull fracture, and also looking at detailed neurological assessment of the upper and lower limbs, focusing onto the lower limb in question as a possible deformed, is it a deformed lower limb or okay, so deformed this right distal tibia. So first and foremost, I need to look at the skin, confirm if this is an open or closed injury. I would then want to palpate the compartments and look if there is any eroding compartment syndrome or any pressure on causing skin necrosis. I would have a detailed assessment and look at if there's any neurological deficit, and also palpate the pulses. If I couldn't feel pulses, I would get a Doppler pulse and then check the capillary refills and the temperature of the leg. I would, for this patient in question, I can see a radiograph of the right, an AP radiograph of the right tibia and fibula. I can see a distal third short spiral, a short oblique spiral fracture pattern that is displaced laterally. I'd like to see orthogonal views of this. I can also see a fracture of the possible fracture of the proximal fibula as well. I can't tell if that's projectional. This patient's in a cast. So moving on, in my management, I can see that there is a cast, some form of cast applied. I would make sure that this is not, if there is a concern about compartment syndrome, first and foremost, I would need to take away the constrictive cast, but I would still try and have some support, because this is a significant, this is a fracture to the tibia. Elevate to the level of the heart, check a diastolic blood pressure, and assess the compartments. I would reassess the patient after removing any occlusive dressings. And at this point, keep the patient nil by mouth, talk to my anesthetic colleagues, escalate this to my registrar and or consultant, and then discuss with plastics colleagues.
Okay, well done. So you can you label each and one of these compartments for me?
Yeah, sure. So there is the anterior compartment. So do you want me to talk about the muscles making up?
And then
yeah,
structures, yeah.
Yeah, so sure. So in the anterior compartment, we have tibialis anterior, we have extensor digitorum longus, extensor hallucis longus, and peroneus tertius. In the lateral compartment, we have, and within that compartment, you have the deep peroneal nerve, and the deep peroneal nerve and the peroneal artery. I'm going to say I'm not making that. In the lateral compartment, you'll have the peroneus longus and brevis, and you'll have the superficial peroneal nerve. In the superficial posterior compartment, you'll have soleus, gastrocnemius, and plantaris. In the deep posterior compartment, which is where you'll have the neurovascular structures of the tibial nerve and the posterior tibial artery, you will have the flexor digitorum longus, flexor hallucis longus, tib post, and gracilis. I can't remember. I'm not sure. I think I might have got one of those arteries wrong. I think so.
No, so yeah, if you're not sure, say it with confidence.
Yeah.
The neurovascular bundle in the anterior compartment would be anterior tibial and
anterior tibial, yeah.
Between the deep posterior and the superficial posterior on the medial side will be your posterior tibial and tibial nerve.
Yeah.
There's also another neurovascular bundle in the deep posterior, just medial to the fibula, which is the peroneal arteries.
Peroneal, okay.
Yeah. And then say it with conviction. So say the big stuff. So peroneal longus, peroneal varus. You can leave out small things like plantaris and
Okay.
peroneus tertius. But yeah, the points.
Okay. Yeah.
Good. Okay. So you talked about the sensory a bit. So how do you examine the nerves in the lower limb motor wise?
To assess the motor nerves in the lower limb, I'd want to assess the tibial and peroneal divisions of the sciatic nerve. So I would want to assess the tibial division. I would want to ask the patient to plantar flex against force, and then also to test the deep compartment. I would want them to flex the plantar flex the foot, and then I'd want to flex the big toe. To assess the anterior compartment, I would ask them to extend the big toe. So extend the big toe, and then to test the lateral compartment. Oh, sorry, I'm mixing between compartments. Sorry, and to test the peroneal division, I would ask them to extend the big toe.
Yeah, so say with deep peroneal.
Yeah, sorry, I got confused. Yeah.
So if say you come back to this case where they're in a back slab, then you say extensor hallucis, flexor hallucis. It's difficult to check lateral compartment.
Yeah.
Yeah, so you can say it. It's all in there. Okay. Yeah. Then it comes back again. Well, we won't go through this anymore. But you've done really well. So 4 hours post-op tibial nail, they'll ask you. They'll suddenly go into an emergency situation where there's pain. They're pressing the PCA nonstop. So what is your approach?
So
do a fasciotomy.
So my approach for this would be I would have an appropriately marked and WHO checklisted patient. I would want this patient to be in supine with a sandbag under the ipsilateral hip. I would do. I would apply a tourniquet, but I wouldn't inflate it. I would ask, do some feed, find out if the consultant want to feed it, and if we encountered a vessel, then we may need to inflate the tourniquet. I would want antibiotics on induction if they haven't been given already. I would want sterile, prep, and drape. I would want to have X-ray as an option, given that there's a fracture. We may need to be nailing this. It seems like an open injury, so we may need to do a concurrent tibial nail or appropriate operation after. But initially I would mark out my landmarks. So my landmarks would be 2 centimeters. I would want to identify the anterior lateral border of the tibia, tibial crest, and I would go 2 centimeters lateral to this, and I would make an incision in line down to go into the anterior compartment. Then once I'm through the skin and subcut, I would extend laterally to make sure I've decompressed the lateral compartment. I would go 12 to 15 millimeters of lateral to the medial border of the tibia. I need to be aware to make sure that the incision is deep enough that I'm not only decompressing the superficial posterior compartment, but also the deep posterior compartment. And I need to be aware of perforators that I can encounter 5, 10, and 15 centimeters above the level of the medial malleolus. Neurovascular structures that I need to be aware of on the medial side are the saphenous nerve and vein. On the lateral aspect, I need to be aware of the superficial peroneal nerve, but also the sural nerve distally.
Not really, but yeah. you've gone too posterior if you've seen the sural nerve. Yeah, so good. So you always have a spill for every single thing, so including simple stuff. This is probably a bit more difficult if you're asked to do a fasciotomy. So as we recapped, You've done really well. Who checklisted marked consented patient, position supine with tourniquet applied, not inflated, antibiotics at induction, sterile, prep and drape, alcoholic chlorhexidine. My landmarks are, you said anterolateral, anteromedial face of the tibia, 2 centimeters lateral, or decompress my anterior and lateral compartments through the same incision. I will decompress the anterior compartment first before embarking on the lateral compartment through the fascia. On the posteromedial incision will be 12 to 15 millimeters posterior to the medial border of the tibia. Watching out for to decompress the deep and superficial compartments, looking for the neurovascular bundle to ensure that I've decompressed the deep posterior. My structures at risk are saphenous nerve on the medial side and superficial peroneal nerve distally on the lateral side. And that's it. Probably 1 minute, you should get everything out. But yeah, you've done really well. Okay, so recap. So we've done this. Thank you everyone for attending. Hopefully that's been a whistle stop on compartment syndrome. If you don't mind scanning the QR code, we will have open fractures next week. Limping child, spines, we'll have a Christmas break, and then we'll go back to talking about ATLS and major trauma. But yeah, thank you everyone. I'm going to stop sharing, so if you guys have any questions, just throw at me.
Thank you very much.
End poll.